Do you think you're getting the hang of these yet? Let's try one more. Again, this is about osteoarthritis. That's the medical diagnosis. That's the things that physicians can do. I didn't write out the whole pathophysiology here because it would be exactly the same as this one on page from page 950. And then on page 953, again, you have one of those green boxes where it gives you your priority problem, also known as nursing diagnosis, and your goal. And this time I chose two. I chose chronic pain, which is the first one there. And it says chronic pain with motion related to loss of smooth joint surfaces. And then I put or. Now on yours, when you turn one of these in, you won't have the or right here. You'll pick either chronic or acute pain and just have one here. But a lot of the interventions are the same, and so I'm just saving space and doing it all in once. So on the flip your page, so on page 954 then, in that green box it has acute pain related to tissue trauma. And again, the goal is there, and the goals are the same. Pain relief, patient states pain is reduced, relaxed expression. Now I had to modify this a little bit because for me, when you turn in a goal for me, you have to have a time parameter. So I added that. Pain is reduced or relieved within 1 hour of intervention. So there's our time parameter there. Your time parameter may be by the end of this shift or by the time of discharge, just depending on what your goal is. But for this one, when we do an intervention for pain, it really needs to work within an hour. If it doesn't work within an hour, we need to try something else. So there's our problem and our goal. Now look on page 955 under acute pain, and we'll start with some of the interventions there. The very first one, it says to assist with, and then I put a number 1, assessment of the patient's pain. So we're going to assess the patient's pain and accurately record the assessment. And it tells you how you do that. And then for the rationale, again, we're getting really familiar with this book by now. Go to page 217. It's a totally different chapter. And note the title of the chapter, page 217. It's pain management. So again, just like we had a whole entire chapter on mobility, we have a whole entire chapter on pain management. And if you look on 217, just under assessment, it says assessment is the first step in pain management. Skip a couple, and then it says accurately record the assessment. This process permits evaluation of the pattern or of pain or the effectiveness of an intervention. And so that's where I got my rationale. Flip back to 955, so hopefully you have something in place there, and go down a few more sentences. It's about the 7th line down. It says, administer analgesics as ordered and document their effects. So that's my second intervention right here. And then to find a really good rationale, again, I went back to the chapter on pain management, page 225. And at the bottom of page 225, the second to last sentence, it starts with the word non-opioids. It says non-opioids tend to block pain transmission peripherally, whereas opioids block pain transmission in the central nervous system. This rationale will make a whole lot more sense to you after we do pharmacology lecture, but that's the rationale behind administering analgesics and documenting their effects. Now, this one looks like it's the same thing, but it's different. It says administer analgesics 30 minutes to 1 hour before painful exercises. Remember that was on my slide presentation, and that again came from page 955. At the bottom it says uncontrolled pain may make the patient reluctant to participate in rehabilitation measures. So there's my rationale right there, and then it says administer analgesics 30 minutes to 1 hour before painful exercises. So these two were just reversed. The rationale came first in the text, and then the intervention, and you'll get the hang of telling which is the intervention and which is the rationale if you're having trouble distinguishing between the two. So then flip back a few pages, because remember this is coming from both acute pain and chronic pain. So we're going to go back to 952 where it talked about chronic pain, and it has some interventions there. It starts with good pain management. A patient can be more active and have a better quality of life. And then, bam, there's your first intervention. Administer analgesic and anti-inflammatory drugs as prescribed. And we already put that back here, administer analgesics, so I'm not going to add that again. And then the second one, it says, in addition, instruct patient in the heat or cold treatments as ordered and monitor and record the effects of the intervention. So provide heat or cold treatments as ordered and monitor and record the effects. Again, if we flip back to the pain management chapter, page 222, it explains why heat and cold is used. And it's on 222, second column, right in the middle. The physician may prescribe the application of heat or cold for pain. Heat or cold is used to reduce muscle spasm and decrease congestion or swelling in the injured area. So that's exactly what I wrote. Then I noticed on 223, so I'm getting these interventions from all over the place, but I love the intervention on 223, distraction. That's one of my favorites. So it's on 223, second column, right under the thing that says health promotion. Then it begins with distraction in bold, and it says, distraction refers to focusing on stimuli other than the pain. Distraction may help the patient to gain a sense of control as well as increase pain tolerance. So that's what I put. Provide or encourage distraction is my intervention. Focusing on stimuli other than pain helps the patient gain a sense of control as well as increase pain tolerance. So there's my intervention right there. Back to 952 to our connective tissue. Again, we're under chronic pain. We already got the administered drugs. We got the heat and cold, and then the very last sentence on page 952, it is important to inform the physician if pain relief measures are ineffective. So that was my final intervention here, inform the physician if pain relief measures are ineffective. And to get the rationale, go back to the pain management chapter, and it's at the very, very beginning on page 212, where it talks about why we manage pain. And we're talking about the Joint Commission, which is one of the things that makes standards that we have to follow. And it starts the last sentence on the first column on 212. It says, because of these findings, the Joint Commission published standards for the management of pain for all patients. Healthcare facilities are expected to comply with these standards, which include: number 1, recognizing the right of patients to appropriate assessment and management of pain. 2, screening patients for pain during initial assessment and when clinically required during ongoing periodic reassessments. And 3, teaching patients and family about the effective pain management. So I had to kind of shrink that down to fit in this little tiny box. So I said, to maintain compliance with Joint Commission published standards, recognizing the right of patients to appropriate assessment and management of pain. You can't really see the bottom of that. So there is already done. So you have 3 priority problem plans that you can copy and use. And so really, clinical ought to be a piece of cake, at least the paperwork portion, right? So just all you have to do is find a patient that has a hip replacement, and you're there. Okay, I have a little bit more time on this section. So we're done with osteoarthritis, and I know it seems like we spend a lot of time on that, but we're over halfway through this chapter. So the first half of the chapter was pretty much dedicated to osteoarthritis. So now we're ready to move on to all of the other things, problems with connective tissue disorders. So we're going to start with rheumatoid arthritis on page 956, and it gives you a definition there. Rheumatoid arthritis, a progressive inflammatory disease, and it is a systemic disorder. So it doesn't just affect the joints, but that seems to be where it causes the most trouble. Systemic means throughout the body. So rheumatoid arthritis can sometimes affect the skin, the eyes, organs, so heart, lungs, liver, all of that. Blood, it can throw off blood counts. It can affect the bones. We're going to focus on the effect that rheumatoid arthritis has on the joints since we're on this chapter, though. Some of the things associated with rheumatoid arthritis are rheumatoid nodules, and I think there might be a picture in your book. Yes, on page 958, it shows you some of the deformities that happen with rheumatoid arthritis. I'm not sure how to say this. Sjogren syndrome. We're going to talk about that later on, but it has to do with the drying out of stuff. Pulmonary fibrosis, which is hardening of the lungs. Kidney failure, vasculitis, so inflammation of the vessels. Osteoporosis, ankylosis, and again, we'll talk about that later on. It is an autoimmune disorder. So autoimmune basically means kind of like an allergy. For some reason, the body attacks itself. And it's not clearly understood, although a lot of research is being done as to why this happens. But there's quite a few autoimmune diseases, lupus, multiple sclerosis. Allergies are kind of considered autoimmune, and then rheumatoid arthritis. And there's some more, but those are the ones that you hear the most about. Now, this type of arthritis is considered inflammatory. Remember the chicken and the egg, which comes first? And we said with osteoarthritis, the injury happens first, which can result in inflammation later. With rheumatoid arthritis, it's the inflammation that leads to the injury. So it's called an inflammatory disorder because the inflammation happens first. It occurs in fairly young people, age 30 to 60, whereas the osteoarthritis generally occurs in the older. It really increases once people reach the age of 60.
Let me check on that.
These next two bullet points are pretty important for distinguishing rheumatoid arthritis from osteoarthritis. This morning stiffness lasting more than an hour. That's pretty specific to rheumatoid arthritis. In osteoarthritis, stiffness might be a major problem, but the stiffness is going to follow activity. So someone wakes up feeling probably pretty good, and then as they go throughout the day with osteoarthritis, things are going to get worse. The more they use that joint, the stiffer it's going to get. Not so with rheumatoid. Their worst time is in the morning. They're going to wake up feeling very stiff and maybe even unable to get out of bed. And so one intervention for that is a warm shower, trying to loosen everything up. Joint involvement is symmetrical. I already talked about that once. And it makes sense because if osteoarthritis is being caused by like a sports injury or something, and I told you like in a tennis player, it's going to affect the arm that they're serving with, or their dominant arm, and the other arm might not be affected at all. With rheumatoid arthritis, it's going to be both. So if it's in the wrist, it's going to be both wrists. If it's in the hands, it's going to be both hands, and so on and so forth, because it's not caused by an injury. It's caused by autoimmune. Treatment of rheumatoid arthritis. Kind of the same as with osteo. We're going to have medication, although the medications are going to differ a little bit because we're going to be trying to turn off the immune system with rheumatoid arthritis. Therapy and teaching, lots of teaching, and maybe even surgery with rheumatoid arthritis. So medication. NSAIDs, first and second generation. We had those with osteoarthritis, right? Non-steroidal anti-inflammatory drugs. This is your Aleve, ibuprofen, those type of things can cause stomach upset, can cause some bleeding disorders. But again, they're usually over the counter and they can be used to treat both osteo and rheumatoid arthritis. So here's where our difference is. Glucocorticoids, we talked about these with osteoarthritis, but I said things like prednisone, the pills aren't really indicated for osteoarthritis. The only glucocorticoids that are used to treat osteoarthritis are those injections that you get right into the joint. And I said those are limited to 3 or 4 a year. Here with rheumatoid arthritis, we do want the systemic effect because remember, back here we said rheumatoid arthritis is a systemic disease. It affects the whole body, and so we want to use these to turn off the body's immune system because the body's immune system is overreacting. That's what autoimmune means. It's overreacting, so we want to turn it off. DMARDs, I'll talk more about in class, and your book tells you about them, but basically we're talking about things like methotrexate, or the biologic Enbrel, Remicade, Humira. These generally have to be given IV, and